Thank you. Thanks for Professor Gan. I also would like to thank for Professor Curigliano for your wonderful presentation. Thanks for walking us through the HR-positive, HER2-negative related research. Well, regarding the 3 questions, I think I've been quite brave in answering the previous question. Let me just be brave. But I have 2 questions to Professor Curigliano. The second question, I think it truly depends on whether the patient have the drug resistance or any visceral things. If indeed the patient have to switch to another treatment, if the patient already started have the visceral crisis, the patient need to have the ADC. And my third point, I think there's something that is hard to be said for. We don't have any head-to-head study of HER2 ADC and TROP2 ADC. However, what would be the final difference? This is also the question I'd like to ask for Professor Curigliano. If I choose TROP2 ADC, TROP2 ADC and HER2 ADC, there are corresponding studies for each. TROP2 ADC, for example, we have A201, and there are some non-HER2 low expression patients, and you should also consider whether the patient have the side effect, or some of the patients have the bone marrow suppressions, very low platelet. Those patients are not recommended for TROP2 ADCs. I have 2 questions to Professor Curigliano. So my question is that for the third question, Professor Curigliano, you can see from the slide, for HR-positive and HER2-negative patient, if the patient already have a drug resistance now, if you provide patient ADC, however, some of the patients are not benefited from the ADC. Some of the patients won't be treated by HER2 ADC. Then, which one should I choose for the patient? Do you believe I can do a clinical trial regarding so? Is it possible for us to have such study? And what would be the best study design for that? And I also have the second question, Professor Curigliano, and he also mentioned that in the advanced stage patient, it seems that ADC and endocrine therapy could be taken as a combined therapy, right, for clinical trial. I really would like to know more for that. Thank you. Thank you. Thanks for Professor Zhao. Now let's welcome Professor Curigliano to provide us the answer. Thank you.
So I see the answer here. Of course, what is the optimal timing for conducting precision mark? Sorry, there is the background of the voice of the translator. If you can mute, please. So regarding the optimal timing for precision. Yes.
So they're trying to, reorganize the question with resistance. With resistance, do we select anti-HER2 or anti-TROP2 ADC? So how could we design a better study on top of that? And as we mentioned before,
let's start from the first, because there are 2 complex questions. The first one is in endocrine resistance, how do you select the ADC? Okay, the first point is based on the level of HER2, because if you have an HER2 low level, the best treatment should be Trastuzumab Deruxtecan. Sacituzumab Govitecan in the ASCENT-7 failed to demonstrate a median PFS benefit in exactly the same setting of the DESTINY-6. Datopotamab Deruxtecan, that included also HER2 low disease, was not an exciting drug. If you look at the data, respect to the performance of TDX in DESTINY-4, the performance of datopotamab Deruxtecan may be due to the crossover was very poor. There was no overall survival benefits. So the selection, in my opinion, regarding the first question, should be based on the level of expression of HER2. If you have an HER2 low disease, for sure, the best frontline treatment should be Trastuzumab Deruxtecan. If you have an HER2 zero, the only option you have until now is or datopotamab deruxtecan or sacituzumab govitecan, even if sacituzumab is a negative trial. If you did not receive chemotherapy, the Asian 7 failed to demonstrate a median PFS benefit when compared to chemotherapy. The data was also explored after chemotherapy. So the only study for which we have data after CDK4/6 inhibitor and endocrine therapy, waiting for the dynasty because there is a trial ongoing that is the dynasty, the only trial actually is the Destiny 6. And this is the first question. Second question, please.
Okay, and the second question is, we talked about HR positive HER2 negative ADC, ABC. If you use ADC plus AT, of course, we have tried chemo. In many cases, chemo is used together with ET. What about ADC plus endocrine therapy? What's your take on that?
Sorry, can you repeat the question? It's not clear. So
这个问题不太清楚，能不能再重复一下？
which is the question? So,
请重复一下最后的那一句问题。
Professor Zhao.
yes. Which is the question? I don't understand the question.
那个
Can someone of you
赵准的意
maybe
思应该就是对于这个 ADC 药物联合类
Yeah,
方
for
面治疗。
ADC in combination with ET, what's your take and consideration?
Okay, so but there is only one study, that is the Destiny 8, in which Trastuzumab deruxtecan was combined both with NAI and with fulvestrant, demonstrating an interesting benefit in terms of response rate, at least the combination with AI, a little bit less with fulvestrant. Usually I don't use the combination of endocrine therapy plus Trastuzumab deruxtecan or sacituzumab. But for Trastuzumab deruxtecan, at least we have one study, and data have been recently published on Annals of Oncology. Of course, in the ideal trial that we should design, the ADC maybe should be tested in those patients who relapsed during adjuvant CDK4/6 inhibitors. So we know that there are some patients, high risk, that received chemotherapy. Then they start adjuvant CDK and they progress. Of course, in a patient population like this is an unmet medical need. I believe really we need to do a trial with ADCs. Because here, what we do usually is to give a chemotherapy to this patient population. So an ideal trial, in my opinion, with an ADC should be a trial in ultra-refractory and resistant patients progressing during CDK4/6 inhibitors. We don't have nothing on this patient population, and what we do in clinical practice is chemotherapy only.